Good afternoon, everyone. Hope everyone's doing well amid this pandemic. Um, so my name is Dr. Michelle Boudreau, and I've been with TeleSpecialists since the end of 2017 as a teleneurologist. And I recently joined the quality team as a regional medical director. I received my master's degree and then went on to medical school at PCOM. And then I completed my residency at UConn and completed a fellowship in clinical neurophysiology at SUNY Buffalo. um, and so I'm board certified in neurology as well as clinical neurophysiology. And I worked at several hospitals before joining TeleSpecialists. And I live in Connecticut, and I have a cat and a husband that I live with, and in my free time, I enjoy performing, singing in choirs and acting. Okay, so without more about me here, we'll dive into this. So, the goals today is to discuss multiple possible presentations of seizures as well as status epilepticus. This will include characteristics of focal, also called partial seizures, and rare generalized onset seizures. We will discuss subclinical seizures, as well as treatment and management of seizures and status epilepticus in the acute setting. We'll discuss the importance of long-term EEG monitoring, as well as briefly discuss the long-term treatment of generalized and focal seizures. All right, so a couple definitions that are important to remember. And these definitions come from the International League Against Epilepsy. So the definition of a seizure is when you have an episode of signs or symptoms that are due to abnormal, excessive, or synchronous neuronal activity in the brain. I often describe this to patients as abnormal electrical activity. Seizures typically last for less than 5 minutes and are self-limiting. When they don't, that's when we get into the more emergent settings. Epilepsy is defined as a disease that occurs when someone has epileptic seizures and his or her brain demonstrates a tendency to have recurrent seizures. So, in order to be diagnosed with epilepsy, an individual will have to have two unprovoked or reflex seizures more than 24 hours apart, or they can have one unprovoked or reflex seizure with at least a 60% probability of having another seizure in the next 10 years. And we'll discuss later what constitutes that 60% probability and how we determine that. And just another definition of reflex seizure is when a seizure is provoked by certain sensory stimuli, or sensitive to certain sensory stimuli. And this can include lights, and that's why during EEGs we do photic stimulation where we have a flashing light in front of them to see if we can provoke a seizure. Also, some people, if they get startled, that can provoke a seizure, and even in some seizures, reading can do that. So status epilepticus, convulsive status epilepticus occurs when you have at least 5 minutes of continuous seizure activity. It can also occur if you have at least two discrete seizures without fully recovering your consciousness between the seizures. Non-convulsive status has varying definitions, and sometimes the only sign that someone is in non-convulsive status is when there is continuous or fluctuating mental status changes. And so one definition is that it's at least 30 minutes of recurrent electrographic seizure activity. Another definition is at least 30 minutes of electrographic seizure activity in the absence of visible convulsion. And I like that last part of that definition because it really stresses the difference between non-convulsive status epilepticus and convulsive status, being that with convulsive, you'll see physically the symptoms, whereas in non-convulsive, you're not. In most cases, you're not going to see them shaking, or you may not even see any symptoms at all, other than the mental status changes. And then epilepsia partialis continua is actually a type of status epilepticus, but it's a focal status. So instead of involving the entire brain, it involves one area of the brain. And you'll because of that, you'll have just one area of the body that's affected. And usually you don't have alteration of mental status with this type of status. So the Neurocritical Care Society tried to kind of take all this together, and they came up with a unified definition of status epilepticus. And what they came up with was that it is at least 5 minutes of continuous clinical and or electrographic seizure activity or recurrent seizure activity without recovery between seizures. So when we classify seizures, there are three classifications. Focal onset, meaning that it begins in one area of the cortex of the brain. Um, Generalized onset, which is believed to have a central origin of either in the thalamus or brainstem, but then it involves all cortices, so the entire each hemisphere of the brain at the same time. And then there's unknown, and that's exactly what it sounds like. We don't know where it's coming from, or how it's starting, and that can be further divided into motor versus non-motor symptoms. So the generalized onset seizures, I'm not going to go over the left side of the screen too much, the motor aspect, because I think most of us in the medical field understand those type of seizures. If you see twitching, if you see shaking or stiffening, it's going to raise a suspicion of seizure. And I think that's easier to identify than the non-motor. The non-motor are also called absence seizures. And then there's three types of these. The first is the typical absence seizures. And this is when you have a sudden onset. A lot of times you'll see eye fluttering and staring. Um, and they're not responsive. Sometimes you'll see automatisms, which uh, examples of automatisms are lip smacking. Sometimes they'll pick at their clothes continually, or slap their hand against their body repetitively. Sometimes head nodding will be seen, and with these, typically you have immediate recovery, and there's no post-ictal state. So sometimes they can actually be missed. And these are actually more common in the pediatric population. And a lot of these patients, especially if it's childhood absence seizures, will grow out of this. There's also atypical absence, where you may not have a sudden onset, it may be more gradual. You may not have immediate recovery afterwards. And then there's myoclonic absence, which combines myoclonic epilepsy and absence epilepsy. So you'll have kind of the staring, eye fluttering, but you'll also a lot of times have myoclonic uh, activity along with it. And a lot of times it's actually eyelid myoclonia, where you have the eyes that are deviating upward. All right, and then for focal onset seizures, these are classified based on level of awareness, um, and then whether they are motor versus non-motor onset, and then if they proceed into secondary generalization. So when we talk about level of awareness, we're not talking about whether they're aware that they're having the seizure or not. We're actually talking about whether they're aware of their surroundings. So when you have what's formerly known as simple partial seizures, the patient will have symptoms, but they'll be completely aware of their surroundings. They'll know where they are, they'll know what's happening, they don't feel out of it in any way. Complex partial seizures are when there's some kind of alteration of their level of awareness, and it can range from they're still awake but they feel outside of their body, or they don't really feel like they're there at one end of the spectrum, or it could be that they lose memory of the event completely. And then the motor versus non-motor onsets. The difference, is somewhat self-explanatory. The motor onset, you're going to see physical motor symptoms, such as maybe a little bit of shaking in an arm or stiffening in a leg. The automatisms can often be seen. Sometimes you can get hyperkinetic movements that are kind of more like abnormal ballistic movements that are not really synchronous. Or you can get, just like, jerks, in one limb or in the face or eyes. And then the non-motor onset, most commonly I see what we call a behavioral arrest. So that's when, someone is doing something, talking, and then all of a sudden they stop what they're doing. And a lot of times, they're like an absence seizure, they may start staring and they're not really responsive. And you may touch them and shake them, but they're not responding. Other non-motor symptoms that you can see on the onset of a focal seizure would be changes in language. So you may see aphasia, difficulty speaking, also thinking difficulty, cognitive difficulty. Deja vu is actually quite common as well. And that's, when I think a lot of us know what that is, but if you don't, that's when you're in a situation and it appears familiar to you, but it shouldn't. You've never been exposed to that situation before. And then the opposite is Jamevu, which is when you're in a situation that seems familiar to you, but it really shouldn't. And then emotional symptoms can be common as well. The feeling of dread, fear, or anxiety. In most cases, I do see negative emotional symptoms like these. However, some people will have, positive emotional symptoms such as pleasure. So that is a possibility. And then the sensory changes we see with the non-motor onsets can include changes in taste and smell. Once again, normally a negative taste or smell, such as a metallic taste in the mouth or a foul odor. However, there are cases where occasionally we'll see, pleasant taste or smell. Changes in hearing and vision can occur as well, once again, depending on what part of the brain that's affected. Pain and numbness and tingling can occur. Um, for instance, if the parietal lobe is involved, you may, get numbness and tingling at the onset of the seizure. And this numbness and tingling sometimes will start in one area and then spread. Kind of have a migratory nature to it, and that just tells us that the seizure itself in the brain is starting in one area and spreading to other areas. And then you can see autonomic changes as well, sometimes before a seizure, and that's blood pressure fluctuations, heart rate changes. Some people will start sweating, their skin color may change, they may even have piloerection or abnormal GI sensations. And then secondary generalization occurs when it starts as a focal seizure in one area of the cortex, and then it spreads and eventually involves the entire brain, both hemispheres. And these are a little tricky because a lot of times as providers, especially in the emergency setting, we get involved when they're in the secondary generalization phase. So at that point, we may not know, is this truly a primary generalized seizure, or did this start as a focal seizure and then spread and become a generalized seizure? And that's why when diagnosing seizures, the history of present illness is very important. And it's important to speak not only to the patient, but also to witnesses. So the patient may be able to tell you if they had any symptoms before they lost memory or consciousness. And that may help lead us into a direction as to, was this more of a partial seizure or was this, more of, a generalized seizure? Asking the patient what's the last thing they remember is important. as well. And then what's the next thing they remember? And then if they do remember parts of the seizure itself, that's important too. If there's a lot of memory lapses, which in often cases there is, then talking to anybody who witnessed the event is important because they'll be able to kind of give you the full picture from start to finish. Past medical history is important because there's certain medical conditions that can predispose people to developing seizures or a seizure disorder, as well as medications. There's certain medications that can trigger seizures. Social history is important. Certain drugs, can trigger seizures as well. And alcohol abuse, I think we all know, has the potential of causing alcohol withdrawal seizures. If someone's used to having alcohol consistently every day and then one day doesn't, they may end up having an alcohol withdrawal seizure. And then with the exam, the vitals are important once again, because on the previous slide we discussed that there can be fluctuations in the vitals. Um, and then the exam sometimes can be helpful, other times it's not. If the patient is post-ictal, sometimes it's difficult to get an accurate exam because they still have some altered mental status. And sometimes, after a seizure, people recover quicker than other people, and their exam may actually be normal, so it's not helpful. But in certain cases where it's helpful, is if you find an abnormality on exam, a focal abnormality, such as weakness. Todd's paralysis is common, especially after generalized seizures, and that involves weakness on one side of the body. However, if somebody had a focal seizure that just involved, an arm or a leg, then afterwards they may just have paralysis in that one area where the seizure was affecting. Um, and then, part of the exam too is, assessing the mental status. Are they easily arousable? Can you arouse them to pain? When you do painful stimuli, are they responding appropriately? That can, give you some kind of sense as to, okay, could they still be seizing or are they just post-ictal? The other thing that I find helpful is if they have a gaze deviation. And a lot of times this helps direct me as to whether they could have had a seizure versus a stroke. And even though there's exceptions to every rule, typically when someone has a stroke, they may have weakness on one side of the body, but their gaze, they may have a gaze preference or deviation. And if they do, it's usually to the opposite side. So in a stroke, if you have right-sided weakness, you may have a gaze preference or deviation to the left side. In seizure, it's actually the opposite. Um, they may have a Todd's paralysis on the right side, but their gaze deviation or preference is going to be to the right side as well. So I always think about it as with seizure, you're looking toward the side of the weakness, whereas with stroke, you're looking away from the side of weakness. And then it's important to also assess for injuries, such as a tongue bite, which sometimes you see, sometimes you don't. And then other injuries like lacerations, shoulder dislocations as well. And sometimes, if you're wondering if the patient actually had an epileptic seizure versus maybe a psychogenic non-epileptic seizure, if they have a shoulder dislocation, more than likely it was a true epileptic seizure, because that's very hard to do in psychogenic non-epileptic seizures. And the next step would be diagnostic testing. And once again, this is a case by case basis. If it's somebody who has a known seizure disorder, who had a breakthrough seizure and comes out of it, pretty quickly and doesn't have any new neurological deficits, or any recent trauma, then you may not have to, get a whole lot of testing. However, if it's someone, who does not have a history of seizures, you want to do the diagnostic testing. Or if it's someone who has a history of seizures, but has any of those red flags the upper part of the slide should be considered for further testing. And so a CAT scan of the head is important in the emergent setting when someone has new neurological deficits, when they don't come out of the seizure um, quickly, where they have persistent altered mental status, or if they have recent trauma or they have a prolonged headache. And we want to do this because we want to make sure that there's no intracranial bleed that could be causing the headache or causing any of the other abnormal findings on exam. And then MRI of the brain, we often get with seizure protocol, especially if the CT is negative, which oftentimes it is. And the seizure protocol is important because it does special slices, especially the coronal slices through the temporal lobes. And that's important because the temporal lobes are highly epileptogenic. So if there's a problem there, the likelihood that someone's going to develop a seizure disorder is a lot higher. And so that's why we want to take an extra careful look at those areas of the brain. And then you want to do it with contrast because, if they have an encephalitis or meningitis, sometimes that won't show as well unless you get it with contrast. Or if they end up having a tumor, you want to see what that tumor does with contrast to figure out, what the next step is. And then an EEG is important. Once again, in new onset seizure, even if they, don't have any red flags, because if it's a one-time seizure, you need to determine, do they have that 60% probability of having a recurrent seizure? And so if they have abnormal neuroimaging or certain abnormalities on EEG, that would increase their risk to probably around 60% of having a recurrent seizure, and that would alter your treatment. And an EEG is also important in the emergent setting when you have, once again, any of these red flags up here. So once again, no timely recovery, persistent or fluctuating mental status. And then if you have the new neurodeficits or unexplained, neurodeficit that's a neurodeficit that's unexplained by imaging. So, and in these cases, you want to get at least a stat EEG, and usually you do want to get long-term monitoring. And we'll discuss the reason for that later. And then certain labs are important. Sometimes people will have an elevated white blood cell count transiently after a seizure. And then after a generalized seizure, the lactate level is often elevated. You don't see that in partial seizures, but you'll often see that in generalized seizures. And then a metabolic, infectious, and toxic workup are important because that will tell us if it was provoked or not. And lumbar puncture isn't needed on all patients. It's just needed if you're suspicious, that an infection is occurring that might have provoked the seizure. All right, so when and why we get long-term monitoring. And so we tend to get that when we suspect the presence of subclinical seizures. So this is seizures that occur intermittently but don't have a lot of physical symptoms to them. And routine EEG is insufficient, and that's because you capture subclinical seizures in 50% or less of cases within the first 2 hours. So that's not a whole lot. But if you have the EEG running for 24 to 36 hours, at that point, you actually have the possibility of catching more than 90% of cases of subclinical seizure. Also, if you're considering non-convulsive status epilepticus, that's important. Once again, because there's usually not a lot of exam findings that you see with non-convulsive status. And so the only way you're going to know is to place an EEG on their head. And part of the definition of non-convulsive status is having more than one seizure, electrographic seizure within a certain time period. So even if you don't catch an electrographic seizure, within the first 20 to 40 minutes of an EEG recording, they may start having, multiple seizures after that. So it's important because of the limitations of the routine EEG to do that longer term monitoring to make sure that they're not in non-convulsive. And then if they are and you're treating it, it helps to make sure that you're treating it appropriately. And then when someone has refractory status, it's important as well. And this occurs when we have seizures that persist despite giving benzodiazepine and a second line longer term anti seizure drug. And with this, we often will intubate the patient and place them on anesthetic. And it's important to get the long term monitoring then because we're even more limited with our clinical exam once they're on an anesthesia. So the long term EEG will help confirm that we've provided adequate treatment. It will also guide the use of the anti seizure drugs. It will help us assess the level of suppression of the seizures. Um, if we're not suppressing them enough, we'll change our treatment, and it will monitor any relapses. And especially when we start to taper the sedation, it's important that we see what the EEG is doing because as we taper it, if the seizures start coming back, we may have to put them back on the sedation. And then in super refractory status, this occurs when the seizures continue to recur 24 hours or more after the onset of anesthesia. And when you start getting into the realm of refractory status or super refractory status, you often want to consider uh, giving enough sedation and anesthesia to obtain a burst suppression pattern on EEG, which we'll discuss in a little bit. And post-convulsive, non-convulsive status, this occurs when you have prolonged convulsive status epilepticus. And the body becomes unable to actually produce intense motor activity. So once again, you may not see a lot of signs of it on clinical exam. There may be subtle signs like jerking of the eyes, the face or extremities, or maybe like a slight jerk, of the arm or leg. But it's thought to be a continuation of convulsive status. And because of that, it's thought to cause continued neuronal injury. And once again, so that's another reason why long-term monitoring may be important because, you may think that the convulsive status has ended, but it actually hasn't. It's just that they were in convulsive status for a long period of time, and now their body just can't, produce the motor activity like it did before. And if long-term monitoring is not available at your facility, and it's recommended, then it's important to transfer the patient for this. And so EEG reads, if you have long-term monitoring unit or capabilities, ideally dedicated licensed EEG technicians and epileptologists should be involved. And we typically read the long-term EEGs twice a day in stable patients. We avoid weaning sedation overnight just because staffing overnight is a lot more scarce than during the day. So if you attempt to wean the sedation overnight and something happens, it's often more difficult to get things under control overnight. Whereas during the day, it's a lot easier. So if we're going to wean them from sedation and see how their EEG looks, we tend to want to do that during the day. We do spot reads in certain circumstances. If the patient is not stable, they have continued seizures. We may take a quick look at the EEG more than twice a day just to make sure that any medication changes we made were effective. And then once again in these situations, we often want to consider a burst suppression pattern and doing the spot checks on the EEG to make sure that's achieved is important. Once that's achieved, we don't normally have to do spot reads after that because once you have burst suppression pattern, you're going to stay that way unless there's some kind of change in the anesthesia, at which point then you'd want to do a spot read. And then, if there are neurological status or exam changes, if they have a seizure, and don't return to their previous baseline in a timely period, then we might want to do a spot check in that situation. Um, and then, as I previously said, weaning the sedation, we'd want to do spot checks shortly after each decrease in medication and anesthesia to make sure that recurrence of seizures is not occurring. So diagnosing generalized seizures, so clinical presentation is important. Family history is important because some and a lot of these epilepsies are found with the family and are genetic or hereditary. And then the EEG will show abnormality or in all leads. It doesn't always, but when we see something like this EEG on the right, that would be consistent with a generalized seizure because you see kind of the spike and kind of slower wave afterwards, spike and slower wave afterwards in all leads. And then focal seizures, once again, clinical presentation is important when diagnosing. MRI findings tend to be more important in these cases because if they have a structural lesion, that may increase our suspicion that they have focal seizures. And then EEG, once again, sometimes is normal, but when it's abnormal, we look for focal findings on the EEG, such as slowing of the waves and certain leads, but not all leads, or you may actually see discharges that look epileptic. And that's what we see here. And this is very common in the temporal lobes. We see these sharp waves here, and that would indicate a propensity toward having focal seizures. And so treatment of convulsive status, obviously, stabilize the patient, get a glucose level to make sure that it's not being, provoked by abnormal glucose levels. Getting IV access is going to be important because that's how you're going to administer your medications and get your blood work. And then benzodiazepine administration is the first line. There's multiple agents that can be used. But it's important to note that early treatment can control status in about 63 to 73% of patients. So that's why it's important to identify and recognize it early because the earlier you treat it, the more likely it is that you're going to get it under control, especially with benzodiazepines. And as we're giving the benzodiazepine, we also want to give a longer acting anti-epileptic medication. And there's several that can be used, and I put this on the slide here. Traditionally, phenytoin, fosphenytoin, and valproate and phenobarbital were used more often. But then when levetiracetam, also called Keppra, came out, we started using that more just because of the tolerability and side effect profile was more favorable. And there's less drug-to-drug interactions with it. And now there's actually some research coming out about Vimpat can be helpful in these cases. And then there's, refractory and super refractory. In these cases, where you give the benzodiazepine and the longer term AED, and if they're still having the seizures, then you want to intubate and sedate with an anesthetic. And propofol is the most common, but Versed or barbiturate can be used as well. Sometimes ketamine can be used. And then if you're having refractory or super refractory status in a patient and you can't really find a cause, you have to think, maybe is this autoimmune encephalitis, which sometimes is a lot more difficult to diagnose. And in that case, you may want to actually consider corticosteroids, IVIG, or plasma exchange if you're thinking that's a possibility. So this is the burst suppression pattern that I previously mentioned, and it's a discontinuous pattern where you have high amplitude bursts of activity followed by suppression in all leads. And during the burst, sometimes it does, it can look epileptic, which is okay. That's very common. But as long as you get this kind of burst and then suppression pattern, that indicates that their brain, activity is where we want it to be. And the idea is that this is supposed to help kind of calm the brain down and help, help ultimately stop the status as we also administer more medication to do so as well. And so there's acute repetitive seizures that occur in people who have a history of seizure disorders. And this occurs when someone has at least 3 seizures within 24 hours, and they normally don't have 3 seizures per day. The mental status is actually normally relatively preserved between the seizures. And so, therefore, we tend not to be as aggressive with these seizures as status. We'll use IV, AEDs and oral or rectal benzodiazepines. Um, and it's actually been shown in studies that an aggressive approach that's used in status may actually be associated with unnecessary morbidity in these cases. And in addition, intubation and sedation may obscure the exam because what we're doing is we're giving the medication and we're trying to see if it's going to decrease the frequency or duration. And we can't really do that when someone's intubated and sedated. So, and these seizures may not be aborted immediately. They often decrease over hours to days. But if the seizures last for more than 5 minutes or the mental status is altered between seizures, at that point it's considered status, and then you have to treat it differently, as we previously mentioned. Epilepsy partialis continua is a localized motor status, and this is usually caused by an acute or chronic destructive lesion, such as a stroke or a tumor. It's localized to one area of the body and is recurrent. It tends to last for at least 1 hour, but usually lasts longer. And people actually have preserved consciousness, but they may have some post-ictal confusion and weakness afterwards. We try to treat it with anti-epileptic medication. It usually takes multiple, and this condition is often drug resistant. So we really want to try to find the underlying cause and treat that. Because that's going to be the better treatment for this. And, once again, because they have preserved consciousness and they don't have, you know, a, a, a prolonged altered mental status, we don't tend to intubate and sedate these patients. So, treatment of non-convulsive status, there's no consensus on this. Once again, addressing any underlying etiology is important. The treatment is often based on their mental status and the clinical course, but we often treat it similarly to convulsive status. So, long term treatment, I'm not going to say too much about this because this can probably be a lecture on its own. But I think the important thing is in the emergent setting is to determine, is it provoked or unprovoked? If it's provoked, let's treat or remove that provoking cause. If it's unprovoked, then we need to figure out, is this an epilepsy or is this a one-time seizure? If it's a one-time seizure, but they have certain abnormalities on MRI and or EEG, then we may consider anti-epileptic medication. Or if they have 2 or more episodes that look really suspicious for seizure and they have normal testing, we may still consider it because a lot of people with seizure disorder will have normal MRIs and EEGs. And then monotherapy versus combined therapy, depends on the situation once again. And then sometimes an acute brain injury will start an anti-epileptic medication, whether they had, a one-time seizure or for prophylactic reasons. And, there's a lot of factors we think about when choosing an anti-epileptic medication. The most important is the spectrum of efficacy. So if someone has generalized seizures, you want to choose one that's effective for generalized seizures. If someone has focal seizures, you want to choose one that's effective for focal seizures. If you don't know, then you're going to want to pick a broad spectrum one that is effective for multiple types of seizures. And the mechanism of action is important because you may try a medication that has one mechanism of action, but if that doesn't work, you may want to try another one that has a different mechanism of action. And then the safety and tolerability is also important because that's also important regarding compliance. Comorbidities are important to keep in mind. For instance, if someone has migraines and seizures, you may want to pick a medication that treats both. And then in young women, you have to think about potential harm to the fetus if they're pregnant or they plan on getting pregnant. And that's once again probably for another presentation to discuss that in further detail. This is a chart about anti-epileptic medication. So I'm not going to go through all this whole chart, but it just shows you that there's certain drugs that, work for certain types of seizures. I did highlight levetiracetam, also called Keppra. And I did this because we tend to use this quite a bit because, as you can see, it's effective for a lot of different types of seizures. And plus, we can give a patient a load of it and get it in their system quickly, unlike lamotrigine, which you can't start quickly because there are too many possible adverse events or side effects from that. And then treatment for breakthrough seizures, determining their compliance is number one. If they're non-compliant, you have to determine why and then figure out how do we get beyond that reason for their non-compliance. Whether it's, do they forget? Do they have to set an alarm? Or are they having side effects and they don't like it? Checking levels of certain medications can be helpful in some situations. Once again, determining if it's provoked versus unprovoked. And then if they have breakthrough seizures, depending on the situation, you can consider increasing their current medication if they're already on one, if there's room to do so. And sometimes checking a level can help you determine if there's room to do so. Or you can add an additional medication. And then sometimes, if they continue to have breakthrough seizures despite trying 2 medications, then you may want to consider a long-term monitoring unit, which a lot of times can be done as an outpatient. They go in for a week. And this helps confirm the diagnosis because sometimes we think they actually have epileptic seizures, but in reality, it's actually something different. And that's why the seizure medication is not working. And then in some cases, if they fail 2 seizure medications, we may want to consider surgery. And you'll need they'll need to go into this epilepsy monitoring unit to help localize the seizure and to determine whether they're a surgery candidate. And then a vagus nerve stimulator is an implantable device, which also can help treat seizures, especially when people tend to have a lot of breakthrough seizures despite medication. So in conclusion, because seizures and status can have many different presentations, it can be easily overlooked in the emergency department and hospital. And this can in turn lead to delays in treatment or appropriate management. Knowing the characteristics of not only focal but rare generalized seizures can help in diagnosing them, which in turn can help in treatment that's timely. Identifying subclinical seizures and understanding their different forms of status can once again help manage them more appropriately and result in less brain injury. And distinguishing between generalized and focal seizures can also help guide long-term treatment. A lot to cover. Not in, a lot of detail on some topics, which we can always do another webinar later on some of the topics I just kind of breezed over.
Again, if anyone does have any questions, feel free to reach out to TeleSpecialists at info@tstelemed.com or reach out to your QPS if you are one of our hospital partners. So, Dr. Boudreau, thank you again for your presentation today. Any closing statements?
No, I just want to thank everyone for coming, and I hope you found the webinar helpful, and feel free to reach out to us with any questions, or if you want to delve into any of these other topics toward the end of this webinar a little bit more, let us know, and we can prepare another webinar for that.
Thank you very much. Everyone, thank you for attending. Stay healthy out there, and we will be announcing our next webinar here soon. Thank you very much, Dr. Boudreau.
Thank you.